Hi, welcome to yet another session of previous year question paper discussion. Straight away into the question. Now we are discussing the 63rd question. Uh, into the question, a 5-year-old boy was brought with complaints of growth of pubic hair. On examination, the child is tall for his age with deepening of voice. Apart from presence of pubic hair, there was increase in testicular size on both sides and increased penile length. Which among the following is or are not likely in the child? So, this is a question of a boy presenting with precocious puberty. So they are asking what are the causes of precocious puberty except. So hypothalamic hamartoma causes precocious puberty, pituitary adenoma also causes precocious puberty, adrenocortical tumor does not produces precocious puberty, they causes delayed puberty. So the option false here is adrenocortical tumor. So what is precocious puberty? It is the onset of secondary sexual character before 8 years in girls and before 9 years in boys, and it's of two types, central and peripheral precocious puberty. Central precocious puberty is GnRH dependent and peripheral precocious puberty is GnRH independent. The causes of central precocious puberty is due to early activation of hypothalamo-pituitary gonadal axis, and for peripheral precocious puberty is due to excessive sex steroids from adrenal or gonads, and the central precocious puberty is idiopathic, mostly in girls, and in males it is due to hypothalamic hamartoma. Then there is a triad associated with precocious puberty, which is known as McCune-Albright syndrome. It's a triad of precocious puberty, cafe spot, and polyostotic fibrous dysplasia. Then the features will be the child will be presenting with premature development of breast, pubic hair, acne, and rapid growth and advanced bone age. Investigation, we will do assess the bone age. Then we will do a basal and GNR stimulation LH by FSH ratio. Then the findings are in central, the pubertal LH by FSH will be raised with GNR stimulation, but in peripheral precocious puberty, there will be a suppressed LH by FSH with GNRH stimulation. Treatment for central precocious puberty, we can give GNRH analogs such as leuprolide, triptorelin, and which and this continuous administration of GnRH analog suppresses the hypothalamo-pituitary gonadal axis. Then for peripheral precocious puberty, we must treat the cause. For example, for congenital adrenal hyperplasia, we should give glucocorticoids. For tumors, we should do surgery. The complications are it will lead to an early epiphyseal closure, which result in short adult stature and psychosocial issues. Then coming to next questions, a 6-day-old term neonate presented with jaundice, the serum bilirubin findings are the total bilirubin 14 mg per deciliter, direct bilirubin 6 mg per deciliter, blood group of baby is A positive, mother A positive. Which among the following makes this a case of pathological jaundice? So they are asking the causes of pathological jaundice. No, which finding will point towards the pathological jaundice? Here, the conjugated bilirubin value will point towards the neonatal jaundice. Neonatal pathological jaundice. So, a few words about neonatal jaundice. Then, neonatal jaundice is defined as the clinical yellow discoloration due to bilirubin of greater than 5 milligram per deciliter in neonates. Then it is classified into physiological jaundice and pathological jaundice. In physiological jaundice, the jaundice appears after 24 weeks. It peaks by 3 to 5 days, and it will bilirubin level will be less than or equal to 12 milligram per deciliter in term and less than or equal to 15 in preterm, and it resolves within 7 to 10 days. The physiological jaundice points presence with the neonate will present with jaundice in less than 24 hours. The bilirubin rise will be greater than 5 milligram per deciliter per day, and conjugated bilirubin greater than 2 milligram per deciliter or greater than 20% of the total, and it will persist for greater than 2 weeks. Then the causes of unconjugated bilirubin anemia in neonate is physiological jaundice, breast milk jaundice, hemolysis, and G6PD deficiency. The causes of conjugated bilirubinemias are neonatal hepatitis, biliary atresia, torch infection, and metabolic disorders such as galactosemia. Then there is an other entity known as breastfeeding jaundice. It has an early onset due to inadequate intake, dehydration, and weight loss, and it is also of late onset. Then the treatment is phototherapy and exchange transfusion in cases of severe hyperbilirubinemia. How can we prevent breast milk jaundice? Continue the breastfeeding, anti-D prophylaxis for Rh negative mothers for pathological jaundice. So, this is about neonatal jaundice. To know more about neonatal jaundice, like physiological jaundice, pathological jaundice, breast milk jaundice, refer to my notes, for which the link is given below. The notes are given in a very crisp form that you can, the explanations of previous year questions are given in the notes very clearly. So go through the notes. Then coming to question 65, a 3-month-old infant presented with history of cough and nasal disease. Coming to question number 65, a 3-month-old infant presented with the history of cough and nasal discharge for 5 days and the first episode of breathlessness for past 2 days. On examination, the child is active and playful. Respiratory rate is 55 per minute, but the chest is hyperinflated. Breath sounds equal with bilateral expiratory wheeze and crackles. Liver palpable 4 centimeter below costal margin, and spine is fast 5 centimeter and is soft. What is the most common acute agent for this condition? So, respiratory syncytial virus. So, it is a case of acute bronchiolitis. So, I have given everything about acute bronchiolitis in notes. Please go through it. Now, I will say a few words about acute bronchiolitis. It is an acute viral infection of lower respiratory tract in infants less than 2 years, and it will be characterized by inflammation, edema, and necrosis of small airway, and it peak within 2 to 6 months, and usually it will appear in child less than 2 years. The most common etiological agent is respiratory syncytial virus. His factors are prematurity, low birth weight, congenital heart disease, chronic lung disease, immunodeficiency. Then the child will present with coryza fever cough, which progresses to tachypnea, wheezing, retraction, nasal flaring, grunting, and hypoxemia. Chest X-ray shows hyperinflation, peribronchial thickening, patchy atelectasis. Then the treatment is mainly supportive treatment with oxygen, adequate hydration, nasal suctioning, but there is no role of antibiotics. Bronchodilators and corticosteroids are not routinely given. Then prevention is by hand hygiene, avoid smoke exposure, crowding. Uh, Palivizumab, it is a prophylaxis used for acute bronchiolitis in high risk infants. It can lead to acute bronchiolitis can lead to apnea, respiratory failure, secondary bacterial infection, recurrent wheezing, or asthma later in life. This is about acute bronchiolitis. Then coming to question number 66. During the initial steps of resuscitation of a neonate with birth asphyxia, when there is a failure of expansion of chest with bag and mask ventilation, what is the first corrective step to be tried? The first corrective step is to readjust the mask. So this is a topic about neonatal resuscitation. Neonatal resuscitation is a very important topic. I have given everything about neonatal resuscitation in the notes. Please download the notes and start studying. So, I will say a few words about neonatal resuscitation or MR-SOPA. The MR-SOPA means it is a step in between neonatal resuscitation. Just now I will tell MR-SOPA, and the detailed classes about pediatrics will be there on 28th September 2025. So now just hear what is MR-SOPA. M means mask adjustment, R means reposition the airway, S means suction the mouth first and then the nose, O means open the mouth, P means increase the pressure, A means airway alternative. So, these steps are known as MR-SOPA test in neonatal resuscitation. Okay. Which among the following condition is not associated with short stature? The answer is Beckwith Whiteman syndrome. Turner syndrome is associated with short stature, Silver Russell syndrome, Cushing syndrome. So this is yet another important topic. Short stature is also recurrently asked in Kerala PSC question paper. Then coming to question number 68. A 3-month-old baby born of second-degree consanguineous marriage was brought with complaints of feeding difficulty, poor weight gain, on examination thin and floppy infant with large protruding tongue, tachycardia, tachypnea, cardiomegaly. This is the keyword. Ejection systolic murmur at upper left sternal border and hepatomegaly is present. Which among the following is a most likely cause? Okay, this is an integration of pediatrics topic with biochemistry. So, which among the following is a most likely cause? The most likely cause is infantile Pompe disease. This is a case of lysosomal storage disorder. So, read everything about lysosomal storage disorder. It has been asked recurrently in every question papers. I have given everything about lysosomal storage disorder in the notes, pediatric notes below. Please download and study it. So, the answer is Pompe's disease. The only lysosomal storage disorder in which the heart is affected is Pompe's disease. How can you remember? Pompe is equal to pump. Pump means it affects the heart pump. So, this way we can remember the Pompey's disease. Then coming to question number 69. A 1-month-old baby with complaints of non-bilious vomiting since second week of life. On examination, thin, emaciated and dehydrated, abdomen distended with visible peristalsis in upper abdomen, USD abdomen clinched the diagnosis. So what is the diagnosis? It is infantile hypertrophic pyloric stenosis. What is the most appropriate step to be taken next? The most important step to be taken is that in infantile hypertrophic pyloric stenosis, there are metabolic disorders. So, first we have to correct the dehydration and correct the dyselectrolytemia. So, the answer is D. Both B and C is the answer. Correct dehydration and correct dyselectrolytemia is the answer. So, sorry, here the answer is most appropriate step is B and C. Correct dehydration and correct dyselectrolytemia first. Correct dehydration, electrolyte imbalance, nasogastric decompression. The definitive treatment is Ramstead pyloromyotomy, which can be done as open or laparoscopic. The prognosis is excellent after surgery, but here the next appropriate step to be taken is to correct dehydration and correct dyselectrolytemia. Then coming to question number 70. Which among the following is a criterion for severe acute malnutrition? Weight less than third percentile, mid-upper arm circumference of less than 12.5 centimeter, weight for length by height less than -3 standard deviation. This is a correct answer. Then coming to severe acute malnutrition, which is a very important topic. We have to learn it. In every question paper, there is a question on severe acute malnutrition. In notes, I have given it very clearly. Read through it. Then I will say a few words about severe acute malnutrition. It is defined as weight for height or length less than -3 standard deviation. First criteria, mid upper arm circumference of less than 11.5 centimeter and bilateral pedal edema. The major cause of it is the major cause of morbidity and mortality in children of less than 5 years, and the risk factors are poverty, recurrent infection, poor feeding practices, low birth weight, maternal infections. Then the types of severe acute malnutrition are marasmus, which leads to severe wasting and no edema; kwashiorkor, there will be edema, fatty liver, and flaky paint dermatosis. Then the complications of severe acute malnutrition are hypoglycemia, hypothermia, electrolyte imbalance, micronutrient deficiency. Then the WHO 10-step management of severe acute malnutrition is: first step is to treat or prevent hypoglycemia. It is divided into stabilization phase and rehabilitation phase. In stabilization phase, there are 7 steps, and in rehabilitation phase, there are 3 steps. In stabilization phase, what we do? We will treat or prevent hypoglycemia, treat or prevent hypothermia, treat or prevent dehydration by the use of ORS or Resomol. We will correct electrolyte imbalance, and we will treat the infection with empirical antibiotic. We will correct micronutrient deficiency. Then cautious feeding by F75 diet. Then in rehabilitation, this stabilization phase is for 1 to 7 days, and in rehabilitation phase it is 2 to 6 weeks. We will catch up the growth by F100 diet, sensory stimulation, and emotional support. We will prepare for follow up. Then in F75 diet, there is 75 kilocalories per 100 ml, which is used in stabilization phase. And in F100 diet, it is 100 kilocalorie per 100 ml, which is used in rehabilitation. Then coming to next question, question number 71. A 3-year-old girl was diagnosed with A 3-year-old girl was diagnosed to have oligoarticular rheumatoid arthritis. She was found to be ANA positive. Which organ is to be urgently evaluated and frequently followed up to avoid complication? So this is a case of juvenile rheumatoid arthritis. So the most common extra-articular manifestation is of eyes, which causes uveitis. So I will say a few words on juvenile rheumatoid arthritis. It is the chronic arthritis of childhood. The onset will be less than 16 years, and it persists for greater than 6 weeks after excluding other causes. The most common chronic rheumatic disease in children, and its peak onset is in 1 to 3 years. The classification are oligoarticular, polyarticular, and systemic. In oligoarticular is the most common. Then there will be ANA will be positive in oligoarticular, and there will be risk of uveitis. The systemic arthritis disease is known as Still's disease, which present with quotidian fever, salmon rash, hepatosplenomegaly, and serositis. Then the clinical feature will be there will be joint swelling, stiffness, pain, morning stiffness. Then the extra-articular features are uveitis, especially in ANA positive oligoarthritis, growth retardation, anemia of chronic disease. Then the imaging X-ray, multidisciplinary treatment is needed, such as physiotherapy, NSAID, DMARDs, biologicals. The NSAIDs for symptomatic cases, steroids for systemic features or severe disease. Methotrexate is the cornerstone DMARD used in juvenile idiopathic arthritis. Then the biologicals can also be given. Then question number 72. 1.5-year-old child with fever and skin rash for past 6 days. On examination, child is irritable, bilateral conjunctival congestion, cheilitis with oral mucosa congestion, left posterior cervical lymph node is enlarged. Then generalized macular papular rashes are present. Initial investigation revealed marked increase in acute phase reactant. What is the most important investigation you will order the next? So this is a case of Kawasaki disease. This is the second question in this question paper about Kawasaki disease. So the next investigation we will order is echo, because there is a risk of coronary artery aneurysm in Kawasaki disease. So the next investigation will be echo. So everything about Kawasaki disease I have given in my notes. Please refer the notes. So I will say a few words. It is an acute self-limiting medium vessel vasculitis of childhood. And it is the most common cause of acquired heart disease in child in developed countries. Then the diagnostic criteria, there should be fever of greater than or equal to 5 days, plus or minus cream features, cream conjunctivitis, non-exudative conjunctivitis, there should be a rash, extremities, there will be erythema, there will be adenopathy, and there will be oral changes like red lips and strawberry tongue. So the coronary involvement will be there. There will be coronary artery aneurysm is a dreaded complication. Then and it is very high in untreated cases of Kawasaki disease. The treatment is IVIG. Aspirin can also be given in high dose in high risk infants. Coming to question number 73, which among the following is the most common congenital heart disease seen in child with Down syndrome? It is endocardial cushion defect. So read everything about Down syndrome from the notes. Okay. It is the chromosomal disorder due to trisomy 21 or due to Robertsonian translocation or mosaicism. It is the most common chromosomal disorder with incidence of 1 in 700 live birth. The child will present with short stature, brachycephaly, flat facial profile, upstanding palpable fissure, epicanthal folds. In palm, there will be a single transverse palmar crease. Then there will be hypotonia in infancy and global developmental delay and intellectual disability. Duodenal atresia, Hirschsprung disease, annular pancreas. There is an increased risk of ALL, acute lymphocytic leukemia in Down syndrome. Then the karyotyping is the investigation. Multidisciplinary management will be needed in child of Down syndrome. Then coming to question number 74. A newborn was brought with complaints of not passing meconium within 24 hours. Which among the following condition could lead to delayed passage of meconium? So the causes of delayed passage of meconium is all of the above. Prematurity, hypothyroidism, Hirschsprung disease will lead to um, delayed pass of meconium in newborn. Usually, the it will newborn will pass meconium within 24 hours. So these are the causes of delayed passing of meconium. I have given everything about it in the notes. Please read through it. In question number 75, a recently married woman. Uh, Then coming to question number 89, all are causes of secondary glaucoma, angle closure glaucoma, except. So they are asking the causes of secondary angle closure glaucoma except. So the answer is pseudo exfoliant glaucoma. So coming to secondary glaucoma is the glaucoma occurring secondary to ocular or systemic conditions, and the causes are ocular trauma such as hyphema, angle recession glaucoma, penetrating eye injury, and there will be inflammation such as chronic uveitis. Then the lens pathology causing secondary angle closure glaucoma are phacomorphic glaucoma, phacolytic glaucoma, lens particle glaucoma, phacoantigenic uveitis. Then proliferative diabetic retinopathy can cause secondary angle closure glaucoma. Central retinal vein occlusion is another cause. Ocular ischemic syndrome, retinoblastoma, malignant melanoma, prolonged corticosteroid therapy. These are some of the causes of secondary angle closure glaucoma. Then coming to question number 90, characteristic feature on slit lamp examination in a case of granulomatous uveitis is. I have said in the class everything about uveitis. Please refer to the class or download the notes for which the link is given below. Okay, characteristic feature of slit lamp examination in case of granulomatous uveitis is mutton fat keratic precipitates. This keratic precipitates, various types of keratic precipitates are recurrently asked in question. So mutton fat KPs are seen in granulomatous uveitis. Then the fine keratic KPs are seen in healed ulcers. Then all keratic precipitate are seen in chronic uveitis or healed lesions. Stellate keratic precipitates are seen in Fuchs heterochromic iridocyclitis. The pigmented keratic precipitates are seen in all uveitis or pigment dispersion syndromes. Okay, I have given everything about keratic precipitates in the notes. Please read through it. Then cherry red spot at the macula is seen in central retinal artery occlusion. This is also a recurrent previous year question. So read what is central retinal artery occlusion. Okay, it is the sudden occlusion of central retinal artery due to retinal ischemia. Etiologies are thromboembolism, giant cell arteritis, trauma, vasculitis, hypercoagulable state. The patient will present with sudden, painless, profound monoocular vision loss. In fundus findings, there will be cherry red spot, pale edematous retina, and attenuated cataract arteries. Complications are optic atrophy, permanent blindness if untreated. The treatment is it is an ophthalmic emergency. Attempt reperfusion within 90 to 120 minutes, ocular massage, anterior chamber paracentesis, carbogen therapy, IOP lowering agents, and treat the systemic cause. Then coming to question number 92. The hallmark of proliferative diabetic retinopathy is neovascularization. So coming to proliferative diabetic retinopathy, it is an advanced diabetic retinopathy with neovascularization. The chronic ischemia will lead to increased vascular endothelial growth factor, which leads to formation of new vessel at the disc, which is known as neovascularization disc or elsewhere. Then the fundus features, there will be neovascularization, pre-retinal or vitreous hemorrhage, fibrovascular proliferation, and fractional retinal discharge, retinal detachment. The complications are vitreous hemorrhage, tractional retinal detachment, neovascular glaucoma. The treatment is panretinal photocoagulation, intravitreal VE, anti-VEGF, vascular endothelial growth factor is the treatment. Then coming to which among the following is toxin mediated streptococcal disease. This is also a pediatric question. Okay, pediatrics carries about 12 marks in Kerala PSC question paper. So you should study Kerala pediatrics. So coming to scarlet fever, it is an acute illness which is caused by group A beta hemolytic streptococcus or streptococcus pyogenes. It affects children from 5 to 15 years mainly, and the transmission is via the droplet. And first it will cause streptococcal pharyngitis or tonsillitis due to exotoxin mediated toxin, and it will produce rash and systemic features. The child will present with sore throat, fever, vomiting, abdominal pain. Then in it also, strawberry tongue is seen. The treatment is penicillin V or amoxicillin. Everything about scarlet fever is also given in the note. Please go through the notes. Then coming to 94, Monroe's microabscess is seen in psoriasis. So I have given everything about psoriasis in the notes also. So a few words, it's a papillosquamous skin disorder. It has a bimodal age distribution. Then the psoriasis vulgaris is the most common form. Guttate psoriasis appears after streptococcal infection. Then it presents with a sharply demarcated erythematous plaques with silvery white scale. There are some nail changes like pitting, onycholysis, subungual hyperkeratosis, and oil drop sign. And in bones, it can present with psoriatic arthritis. Hospit sign is present in psoriasis, which is pinpoint bleeding after scraping the lesions. Then treatment is by emollients, keratolytic topical steroids, systemic treatment by methotrexate, then phototherapy by narrowband UVB or PUA therapy. Okay, so read everything about leprosy from the dermatology notes, for which the link is given below. Which clinical type of leprosy does occur with leonine facies? So lepromatous leprosy present with leonine facies. Okay, leprosy is a very important topic. You have to read about leprosy from the notes. I have given everything, the classification, the lesions, the management program, everything in the notes. Then coming to necrolytic migratory erythema is associated with, this is an integration medicine integrated with dermatology. These are the findings, dermatological findings in internal malignancy. There is a topic, I have given everything about it in the notes. So here the answer is necrolytic migratory erythema is seen in glucogonoma. Then coming to question number 97, which of the following is the current law in relation to admission of mentally ill patients in India? It is Mental Health Care Act. This can also be repeated because there are so many changes in this act. I will say a few words about this act. It protects the rights of person with mental illness, and it ensures accessible and affordable care for mental illness patient. The rights of mental illness patient are right to access mental health care, right to community living, right to protection from inhuman treatment, right to confidentiality, right to legal aid, and right to complaint. So there is an advancing directive in which the person with mental illness can specify the treatment preferences and nominate representative for the same. Uh, this is a change in this Mental Health Care Act. So please read through it. I have given everything about Mental Health Care Act in community medicine notes. So please read through it. So I am discussing this question paper just to familiarize you with the question, how the questions are asked, and what all areas should be focused. This is from one question paper. So I have prepared the notes in such a way that you don't have to refer the previous year question paper back again. I have given everything in the notes, and I have marked in the notes PYQ in every area where the questions have been asked from the past previous year question papers. So go through the notes, and I have highlighted the same also. Then after every notes, I have given a Kerala PSC question bank to practice, to assess yourself whether you are thorough with the topic or not. So see you in next video. Thank you.